Assalamu alaikum. So welcome everyone to our second session titled Commitment to Responsibility and Ethics, a Professional Healthcare Approach. We'd like to welcome our moderators, Dr. Amin Al-Atwan, Dr. Sousan Al-Bannai, and Dr. Shayma Al-Faris. We will start the second session with a video titled Lessons Learned: Pioneering Changes in Healthcare Amidst COVID-19.
بسم الله الرحمن الرحيم. طبعا مع بدء حملات التطعيم لمرض كوفيد-19 في دولة الكويت، شاركت الطواقم الطبية في الرعاية الصحية الأولية هذه الحملات، وكانت على 3 أصعدة. الصعيد الأول كان من خلال الحملات الميدانية المتنقلة. تقريبا استهدفت هذه الحملات 325 ألف مواطن ووافد ومقيم في الفترة اللي تم يعني الحملات الميدانية هذه. فكانت هذه الحملات تقريبا حملات متنقلة مكونة من طواقم طبية وتمريضية ومسعفين، كانت متوزعة في 6 مناطق صحية. كانت تنطلق هذه الحملات الميدانية المتنقلة لاستهداف تطعيم المواطنين والمقيمين في دولة الكويت. فبدينا طبعا باستهداف الموظفين اللي في الجمعيات التعاونية، المساجد، الحضانات، الصالونات اللي داخل المناطق، يعني كل الأماكن الحيوية اللي في المناطق اللي تقدم أي خدمات استهلاكية أو يكون المواطنين والمقيمين لهم احتكاك مباشر معهم. عقب ما خلصنا المناطق السكنية بدينا نتجه حق المولات، الأسواق، بدينا نستهدف حتى قاعات السينما، الموظفين اللي هناك. أيضا استهدفنا المصانع اللي تقدم معدات استهلاكية، فاتجهنا حق مصانع الأغذية، مصانع السيارات، كل المصانع اللي نحس إنها مهمة وحيوية لتقديم خدمات للمواطنين. ومن ثم اتجهنا حق المناطق اللي فيها كثافة سكانية عالية، وحسينا إنه يعني يتوجب علينا أن نستهدف المقيمين اللي هناك. فوايد الحملات الميدانية استهدفت مناطق بعيدة ومناطق قريبة، مثل الجليب شيوخ، العبدلي، شبد، الوفرة. ومن ثم طبعا عندنا بعد الحملات الميدانية المتنقلة عندنا حملات طريح الفراش. هذه الحملات استهدفت المواطنين والمقيمين اللي عندهم إعاقة شديدة أو طريح فراش من جميع الأعمار، سواء كانوا كبار السن أو أطفال، واللي يصعب عليهم يعني إنهم يجون المراكز التطعيم. فبدينا نستهدفهم ونطعمهم عن طريق هذه الحملات المتنقلة لطريح الفراش. كان في عندنا طريقة وفرنا رابط للتسجيل حق اللي يحتاجون، عندهم هالفئات من العمرية أو الفئات هذه المستهدفة، يسجلون برابط، وكنا نتجه إلى مكان سكنهم ونطعمهم. طبعا هذا الفريق كان مكون من سيارات إسعاف فيها طبيب وممرض ومسعف، وفي هذه السيارات الإسعاف كانت مجهزة في جميع التجهيزات اللازمة اللي يحتاجها الطواقم الطبية. تقريبا طعمنا ما يقارب 3500 مواطن ومقيم اللي يتبعون هذه الفئات. طبعا غير الحملات الميدانية وحملات طريح الفراش، عندنا المراكز الصحية. تقريبا شارك 81 مركز صحي في الكويت في التطعيمات. طبعا كان يساند المركز الرئيسي اللي هو مركز مشرف للتطعيمات. طبعا المواطنين والمقيمين اللي طبعا يصعب عليهم الوصول مركز مشرف. وطبعا كل هذه التطعيمات كانت تكون عن طريق مواعيد محددة لكل مستهدف، إلى موعد مسج بالتليفون على حسب الموعد والمكان يتجه لتقديم الخدمة حقه.
مما لا شك فيه أن مراكز الرعاية الصحية الأولية هي البوابة الأولى اللي يقصدها المراجعين لتقديم الخدمات الصحية. وأثناء تفشي جائحة كورونا أثبتت هذه المراكز الصحية دورها الفعال في يعني التعامل المبكر مع هذه الأزمات ومع هذا الوباء بشكل خاص. تم بداية نشر خبر وجود جائحة كورونا ووصولها إلى البلاد، عقدت سلسلة من الاجتماعات يرأسها رئيس الرعاية مع رؤساء المراكز الصحية وأيضاً رؤساء الوحدات ومكاتب الخدمات في المنطقة. بحثت هذه الاجتماعات مستجدات وآخر التوصيات العالمية، ومن خلال الاجتماعات تم وضع آليات عمل ومتماشية مع البروتوكولات العالمية وحسب توصيات فريق كوفيد الوزاري والذين كنا نمثل قطاع الرعاية الصحية الأولية فيه لتغطية العمل في المراكز الصحية واستحداث الأقسام المعنية التي قد تساعد في المهام المنسوبة للموظفين. فقد تم استحداث نظام ومنطقة الفرز وذلك لفلترة الحالات، وأيضاً تم استحداث غرف للعزل لعزل الحالات المشتبه فيها، وأيضاً استحداث عيادات للحالات المشتبه بها بإصابتها بالحالة التنفسية ولعمل اللازم لها بعيداً عن بقية المراجعين وعزلها عن باقي المراجعين في المراكز الصحية، وذلك لتقليل نشر العدوى. كما تم تدريب الطاقم الطبي على توصيات إدارة منع العدوى واستخدام وسائل الحماية الشخصية. كما أن استمرت مراكز الرعاية الصحية الأولية بتقديم الخدمات الصحية للمراجعين في عيادات العامة وعيادات طب العائلة وأيضاً عيادات التخصصية بكامل خدماتها، واقتصرت على الخدمات الأساسية. وتم إغلاق بعض العيادات التخصصية التابعة للمستشفيات مثل عيادات الأنف وأذن والحنجرة والعيون، واقتصار الخدمات على الخدمات الأساسية في المراكز الصحية، وذلك تقليلاً لتعرض المراجعين لعدوى الفيروس. تم من البداية توفير خدمة توصيل الأدوية للمراجعين من خلال الطواقم الطبية من أطباء وصيادلة وإداريين وفرق تطوعية من أهالي المناطق ومن أعضاء المدن الصحية. تم إدراج أيقونة جديدة في النظام الآلي وهو Suspected Cases of COVID-19، وذلك لحصر الحالات المشتبه بها تسهيلاً لعمل الإحصائيات. تم تكريس مركزين صحيين للعمل على تقديم الخدمات الصحية للمصابين بمرض كورونا، وتخصيص أحد المراكز للمواطنين والآخر للمقيمين. تقدم من خلالها الخدمات الصحية كاملة من معاينة المراجعين وأيضاً عمل التحاليل المخبرية وأيضاً تقديم الأدوية وتحويل الحالات الطارئة إلى المستشفيات تلقي العلاج، وأيضاً تحويل بعض الحالات إلى المحاجر لتوفير المسكن المناسب مع متابعتها ومن خلال تطبيق شلونك ومتابعة الحالات إلى أن تتم شفائها. تم أيضاً الحرص على تعقيم المراكز الصحية وعمل الإجراءات حسب توصيات إدارة منع العدوى وبواسطة استخدام المعقمات ورش المعقمات في المراكز وأيضاً في المباني المحيطة فيها. تم إغلاق بعض المراكز الصحية في الفترة المسائية وذلك وتوأمتها مع المراكز الصحية المجاورة لها وتقسيم العمل بالتناوب، وذلك حفاظاً على الموظفين من التعرض لخطر الإصابة بالأوبئة. تم أيضاً استمرار اللجان العلمية في عمل المحاضرات ومن خلال برامج زوم وتيمز، وذلك لتقديم المحاضرات العلمية والتي تخص آخر المستجدات والتوصيات العالمية. حرصت الرعاية الصحية على العمل في ضمن فريق عمل متكامل متعاون من جميع الطواقم الطبية والفنية والإدارية لتقديم الخدمات في يسر وسهولة للمراجعين وحفاظاً على سلامتهم وسلامة ذويهم. تم الحرص على تقديم الدعم النفسي والمعنوي للطواقم الطبية، وذلك لدعمهم من ناحية تقديم أفضل الخدمات والصمود في ظل والعمل تحت الضغوط في ذلك الوقت لاستمرار الخدمات الصحية واستكمال العمل في المنظومة الصحية ودعم الجهود وتقديم خدمات عالية الجودة ومتماشية مع توصيات السلامة والمنع العدوى. تم تخصيص مجموعة من الأطباء وأفراد من التمريض للعمل في المحاجر الطبية كفرق مساندة، وأيضاً في عملية الإجلاء والعمل في المطار الدولي والمستشفيات الميدانية، وكفرق مساندة لأقسام الصحة الوقائية، وأيضاً في الزيارات الميدانية للفحص السريع للجمعيات والمدارس، وأيضاً في الحملات الميدانية وتقديم التطعيم ضد فيروس كوفيد في المراكز الصحية التابعة للرعاية. عمل وحدة الرعاية وفريق العمل من جميع التخصصات ومن جميع الأقسام، والعمل بروح الفريق الواحد والتركيز على الواجب المهني والإنساني كان فوق كل اعتبار، والتضحية والصمود وتحمل الضغوطات كان له أثر كبير في التغلب على هذه الجائحة وإنهائها بأقل الخسائر الممكنة في ظل تعليمات القيادة ووزارة الصحة.
السلام عليكم ورحمة الله وبركاته. أحب أتكلم عن الإجراءات اللي تم اتخاذها من مراكز الرعاية الصحية الأولية بصفتي رئيسة مركز رعاية صحية أولية. عندما تم الإعلان رسمياً من قبل منظمة الصحة العالمية عن جائحة كورونا أو جائحة كوفيد-19، تم تطبيق البروتوكولات الوزارية اللي تم إصدارها بصورة مستمرة، حيث تم إصدار بروتوكول وتم تحديثه لمدة 10 مرات، أي أن توتال مجموع 11 بروتوكول. حرصت مراكز الرعاية الصحية الأولية على تطبيقها، وذلك لحماية الأفراد والمراجعين المراكز. طبعاً لأن مراكز الرعاية الصحية الأولية تقدم شريحة كبيرة من أفراد المجتمع، ومعظمهم ذوي طبيعة خاصة، حيث أن الكثير منهم من فئة كبار السن أو ذوي الاحتياجات الخاصة أو المصابين بأمراض مزمنة، مما يشكل نقص في المناعة عندهم. وحرصاً منا وخوفنا عليهم حرصنا على عمل العديد من الإجراءات الاحترازية للحفاظ عليهم. تم عمل نقاط ترياج أو نقاط كشف مبكر عند باب المركز عند مداخل مراكز الرعاية الأولية. حرصنا أن يكون فيها طبيب وممرض يتأكد من صحة المراجع اللي قبل لا يدخل المركز إذا كان عنده بعض الأعراض. تم وضع بانر بلغات مختلفة غير العربي والإنجليزي، مثل اللغات السائدة في المجتمع مثل اللغة الإيرانية، الهندية، الفلبينية، على أساس يتم التأكد من صحة جميع المرتادين المركز، تجنب الاختلاط مع الفئات ذوي عوامل الخطورة. بعد اجتياز مرحلة الفرز أو الترياج يتوجه، حطينا علامات في المراكز الصحية، حرص على التباعد، الكراسي الانتظار تم تغطية بعض منها بحيث يكون في تباعد في انتظار المرضى في العيادات. تم توزيع الكمامات وأدوات التعقيم في جميع أنحاء المركز للعاملين وللمراجعين. الكحول، التعقيم المستمر، هذا كله كان من ضمن الإجراءات المبدئية للحد من انتشار المرض. تم أيضاً تقديم خدمات مجتمعية عديدة لأفراد المجتمع. تم تفعيل دور الفون كونسلتيشن أو خدمة الاستشارات الهاتفية للرد على استفسارات المرضى إذا كان عندهم أي أسئلة، أي مخاوف. تم إرشادهم على الآلية وكيفية التصرف، مثلا when to call for help، متى يحضر المريض للمستوصف أو للمركز الصحي لتلقي الخدمة، وإذا كان في إمكانية تجنب حضوره يتم الإبلاغ أو الرد على استفساراتهم. أيضاً من الأشياء أو من الخطوات اللي تم اتخاذها في ذاك الوقت هو تفعيل دور السوشيال ميديا أو التواصل الإعلامي. تم تفعيل دور الانستغرام المركز، كان في العديد من التوجيهات، الإرشادات الصحية للمراجعين وللفئات المجتمع كافة بمختلف اللغات عن الآلية والخطوات اللي تعينهم للحد من انتشار المرض بين أفراد الأسرة، بين أفراد المجتمع. كيفية التصرف في حال الاختلاط مع حالة مشتبه فيها، إذا كان عندهم أعراض كيفية التصرف، إذا كان في أي اشتباه الحالات مخالطة، ما هي الإجراءات الواجب اتخاذها، وذلك تطبيق البروتوكولات وتبسيطها للعامة. بعد نقل الشخص المشتبه إصابته بالكوفيد 19 إلى الجهات اللازمة، يتم تعقيم المنطقة بالكامل من غرف انتظار ومن عيادات، وتبديل جميع المستلزمات المتعلقة، وذلك حرصاً على عدم نشر العدوى للمرضى الذين كانوا موجودين في هذه الأثناء أو بعد نقل المريض من المركز. كان يتم بصورة يومياً الإبلاغ للجهات المختصة عن الحالات اللي تم الاشتباه فيها، كانت بمعدل حالة إلى 3 حالات يومياً. في هذا المعدل يتم التواصل والإبلاغ عنها. بعد ظهور اللقاح واعتماد لقاح كوفيد 19 لتخفيف العبء للمراجع وللمواطنين وللسكان الكويت، تم فتح مراكز الرعاية الصحية الأولية في مختلف المحافظات، كان من ضمنها مركز بدر النفيسي ضاحية عبد الله السالم لتقديم خدمة التطعيم للمراجعين بعد أخذ مواعيد ووفق سياسة وضوابط وزارة الصحة. تم خلال وسائل السوشيال ميديا توعية المراجعين عن أهمية الحفاظ على صحتهم النفسية. ما يخفى عليكم أن ظهور الجائحة، الإصابات المختلفة، سماع الأخبار المقلقة قد يسبب للمرضى بعض التوتر، الارتباك، الخوف، فكان في إرشادات كثيرة للمراجعين وللسكان المنطقة والسكان الكويت عامة عن كيفية تدارك والحفاظ على سلامتهم النفسية وصحتهم الاجتماعية.
طبعاً لما نتحكي على المحجر هو عبارة عن فكرة أنك توفر بيت حق شخص بينعزل عندك، المحجر كان فيه طواقم كثيرة، طاقم طبي، طاقم أمني لحفاظ الأمن في المحجر، طاقم تمريض، يعني كان شيء متكامل الحمد لله. طبعا بالنسبه حق الطاقم الطبي بتكلم عن احنا دورنا كاطباء عائله، الامانه كانت مسؤوليه علينا وايد كبيره، خصوصا ان احنا كنا خط الدفاع الاول. يعني انا عاشرت الاثنين، في البدايه كنت في المستوصف وبعدين انتقلت الى المحاجر. بس بالمحاجر باختصار، المحاجر كنا نستلم المرضى ونسوي لهم ترياج ونقرر منه اللي يقعد عندنا وستيبل وانه ما في شيء. على العموم التجربه عدت لله الحمد. احنا دورنا كاطباء عائله الحمد لله والشكر قمنا بمهمتنا على اكمل وجه والحمد لله.
السلام عليكم، حياكم الله. اليوم حاب اكلمكم عن دور اطباء العائله في اثناء فتره الجائحه، حيث تم استدعاء جميع اطباء طب العائله من قبل وزاره الصحه، والغرض من هذا الاستدعاء كان هو المشاركه في تاسيس المحاجر والمستشفيات الميدانيه. طبعا شاركت في المستشفى الميداني في منطقه الجليب، حيث تم تقديم الرعاية الصحية لسكان منطقة الجليب بعد أن تم إغلاق جميع المداخل والمخارج. في المستشفى الميداني تم فرزنا إلى فرق مختلفة، كان فريق مختص في عمل المسحات للمخالطين والمصابين، والفريق الثاني كانت مهمته متابعة الحالات الإيجابية بشكل يومي. بعدين كان في فريق ثاني مهمته هو إنشاء المحاجر داخل منطقة الجليب. كان في محجر مختص في النساء والأطفال ومحجر مختص بالرجال، بالإضافة إلى المستشفيات الميدانية والمحاجر اللي ساهمنا في تشغيلها. ساهمنا في إنجاح خطة الإجلاء المواطنين اللي في الخارج، والتي كانت بتوجيهات مباشرة من المغفور له صاحب السمو الشيخ صباح. في المطار تم تقسيمنا إلى 3 فرق، مهمتها الأساسية أولاً كانت فرز الحالات، وبناء على الفرز كنا نحدد إما الشخص يتوجه إلى الحجر المنزلي أو المؤسسي. الفريق الثاني كانت مهمته العمل المسحات، والفريق الثالث كانت مهمته الأساسية والرئيسية تفعيل برنامج شلونك ومتابعة المخالطين.
Our next session is Approach to the Hematuria Patient by Dr. Saad Al-Dosari. Dr. Adosari is the hospital director and chairman of Department of Surgery at Sabah Al Ahmed Urology Center, a tertiary center for adult and pediatric urology. He is currently an associate professor in the Department of Surgery, Urology Division at Kuwait University, and an adjunct associate professor in the Department of Urology at MD Anderson Cancer Center in Houston, Texas, USA. Dr. Adosari obtained his MBBCH degree from the Royal College of Surgeons in Ireland in 2003 and completed his residency training at McGill University in Montreal, Canada in 2011, followed by a Society of Urologic and Oncology Fellowship at MD Anderson. He is currently the Faculty and Residency Program Chairman at KIMS for Urology. His research interest includes prostate and kidney cancer. His clinical practice is focused on general urology and uro-oncology with interest in advanced robotic surgery. Please welcome Dr. Saad Adosari.
Thank you so much. I'd like to thank the organizing committee for the invitation. It's such a pleasure to be here in the presence of distinguished speakers and guests. And I'd like to take this opportunity to congratulate the residency program of family medicine for achieving the accreditation, and also appreciate the hard work done at KIMS to always push us to reach the highest educational standards. So this is a moment for all of us to be proud of, so congratulations. So I was given 25 minutes plus 5 minutes for discussion to talk about approach to the hematuria patients. So we're going to be switching gears now and talk a little bit clinical. Hematuria is a very common presentation in the urology clinic. 20% of urological evaluation is for patients with hematuria. I'm not here today to talk to you about what we do for the hematuric patients. I'm here to underline the crucial role primary health care has in evaluating and managing patients with hematuria. Knowledge of the differential diagnosis, the principles of evaluation, and the strategies of management start with primary health care. You cannot refer all patients with hematuria to be worked up by urology. At the same time, you don't want to be the person missing the patient who has an underlying genitourinary malignancy. So the responsibility on primary health care is to identify those patients who should be referred for urology evaluation to uncover a hidden genitourinary malignancy. In addition, patients' expectation is crucial when counseling patients. Patient should expect what is the value of the referral, what to expect as the results of the evaluation and management. And this doesn't start with the urologist, it starts with primary health care. So I'm going to be touching on classification and definitions of hematuria, specifically microscopic and gross hematuria, some special considerations in patients presenting with this symptom, and what has been done for patients with this important symptom. Hematuria can be classified according to timing of the hematuria, either initial, meaning the urination starts with blood in the urine, and this usually reflects the etiology being from the bladder neck and distal, so urethral origin. Or it can be terminal, reflecting the trigone, bladder neck, or prostate as an etiology. Or it can be a total hematuria, so blood is present throughout urination. This reflects the etiology being from the upper tract or the bladder, so the blood is mixed with urine. Or it can be classified according to how it looks. Blood visible to the naked eye in urine is called gross hematuria. However, blood that's detected by urine analysis and microscopy is called microscopic hematuria. This should be distinguished from pigmenturia or pseudohematuria. There is an array of causes of red discoloration of urine that is not caused by hematuria. So there is a lot of medications which include chemotherapeutic agents. We have pyridium, which is a medication used to treat dysuria in patients, and anti-TB medications such as rifampicin. Some foodstuff result in red discoloration of urine, such as beets and blackberries. And some metabolic disorders. So jaundiced patients, patients with rhabdomyolysis can have dark brown or red colored urine. And the way to distinguish pseudohematuria from true hematuria is by doing urine analysis plus microscopy. If you do urine analysis only, you're going to have positive blood plus RBC. However, to distinguish pseudohematuria from true hematuria, you do microscopy, and you should see RBCs in the microscopic examination, and this determines that this patient has hematuria rather than pseudohematuria. So the most common presentation of hematuria to primary health care is asymptomatic microscopic hematuria. So what is the definition? A lot of societies, urological societies, tried to define microscopic hematuria over the years. And we see here that there is an agreement that the presence of 3 or more RBCs per high power field is the definition of microscopic hematuria. The difference, though, between these associations is how many samples is required to name this microscopic hematuria. The Canadian Urological Association recommends 2 positive urine samples out of a total of 3 to start evaluating patients. However, the American Urological Association, the Japanese as well, they recommend starting the workup after a single positive microscopic hematuria. However, there is an algorithmic workup that is detailed very nicely by the American Urological Association, and the focus in this talk is going to be on that recommendation. We have to differentiate between the commonest cause of hematuria from the most serious cause of hematuria. The commonest cause of hematuria in males is benign prostatic hyperplasia, which is not a cancerous etiology. In females, though, it is urinary tract infection. But there is a large list of causes of hematuria, starting from malignancy, stones, congenital malformations, or medical causes. There is also benign causes of hematuria, which probably does not require urological evaluation. So marathon runners, they usually have microscopic hematuria due to the strenuous physical activity they do. Menstruating females, recent instrumentation, recent sexual intercourse, a febrile illness above 40 degrees Celsius, all these can result in microscopic hematuria and should be distinguished as gynecologic or benign causes of the hematuria. And this is where the role of the primary healthcare physician is important. When we look at the age distribution, it's very unusual to have malignancy as a cause of hematuria in patients younger than 20 years of age, and vice versa. It's unlikely to have a congenital cause as the cause of the hematuria in patients over the age of 60. So screening studies that looked at healthy participants identified a 6.5% prevalence of microscopic hematuria among healthy subjects. Of these, 1 to 2/3 have an underlying genitourinary malignancy. And this is where the role of the primary healthcare physician is, to identify those at risk of having a hidden malignancy and refer these in a timely fashion to avoid progression of disease. At the same time, you don't want to refer a lot of patients and overload the healthcare system with these investigations. Investigations for hematuria can be invasive, and they are expensive. So there has been publications identifying patients who should be evaluated completely for hematuria. Those with a high level of microscopic hematuria, namely more than 25 RBCs per high power field. Those with current or previous gross hematuria. Males who are over 50 with a heavy smoking history. In the presence of risk factors for urothelial malignancy, such as chronic irritation, those with indwelling Foley catheters, previous exposure to radiation, or previous exposure to carcinogenic chemotherapeutic agents, and so on. Family history, of course. The presence of these factors increased the likelihood of finding a genitourinary malignancy from 1.5% to 11%. So I'm not going to refer a patient with 1.5 risk of finding a malignancy to undergo CT scan with contrast, cystoscopy, cytology, compared to another patient with 11% risk of finding a malignancy. So this is where we filter patients who require referral. And let's not forget patients with genetic predisposition to having malignancy. Usually these patients walk into your clinic and they know that they have this inherited disorder. Most commonly in Kuwait is the VHL. So this nice algorithm made by the American Urological Association, it's almost made for primary healthcare. It starts with identifying the patient with microscopic hematuria. So the presence of 3 or more RBCs per high power field triggers the workup. So after we identify this patient, we ask the patient questions and examine him to see, is this likely to be from a benign cause, a gynecological cause, or the patient has risk factors for malignancy. The evaluation is directed towards identifying a gynecologic or a benign cause. Patient having a recent Foley catheter insertion, patient who's currently menstruating, patient who had a recent febrile illness. After identifying these benign or gynecological causes, we treat the cause and then repeat the urine analysis. If the patient has a negative repeat urine analysis, then the patient will be released from care. However, if there is a risk factor of malignancy, then we have to stratify patients. Are they low risk for having a genitourinary malignancy, intermediate, or high? Those in the low risk category have to have all of these factors, and these are to do with the gender, age, smoking, degree of the hematuria, presence of history of hematuria in the past, and presence of any risk factors for genitourinary malignancy. In the intermediate and high risk group, we see the risk factors getting worse and worse. So heavier smoking, older age, males, presence of gross hematuria, and so on. After we stratify patients, then we determine what to do next. It says in this algorithmic workup, patients in the low risk group, you can defer workup by repeating urine analysis within 6 months and see if it's still positive. I personally, as a cancer surgeon, would argue against. I would recommend for anyone, if you have the slightest suspicion of this patient harboring malignancy in the presence of any of the risk factors for GU malignancy, do not hesitate in referring these patients. Now, what about a patient with intermediate or high risk factors, and you perform the workup and evaluation, and it's negative? I would say I would never discharge this patient. I would discharge him from my clinic, bring him back in 3 to 6 months, and repeat urine analysis again. And if there is still positive microscopic hematuria, I would repeat the workup. And we can repeat this for a total of 2 years. And this is all because sometimes genitourinary malignancy is hidden. You cannot see it, specifically carcinoma in situ. It doesn't look like a cauliflower or a papillary growth. It looks like a velvety, patchy red areas inside the bladder. And the most common genitourinary malignancy that results in hematuria is bladder cancer. Now, this is a more simplified algorithm that explains what to do for patients with asymptomatic microscopic hematuria. So if the patient is identified as someone having microscopic hematuria, we rule out the benign causes and the gynecological causes. And then we follow the algorithm, which is simplified, similar to the algorithm present in the previous slide. The only important point I would stress is, if you have any suspicion, do not let the patient go. When we say workup, we talk about doing urine tests, which includes cytology. We do imaging, preferably CT urography. If the patient has allergy to contrast, elevated renal function, or the patient is pregnant, you cannot do X-ray imaging. You can do an ultrasound combined with retrograde pyelogram, or you can do an MR urogram. And this substitutes for the CT urography. So we have urine test, We have imaging, and we do cystoscopy, which no imaging can substitute for looking inside the bladder with a cystoscope. So when we say cystoscopy, these are the devices we use. The picture on the right side is a flexible cystoscope. It is done in the office under local anesthesia, making sure the patient doesn't have an infection. Daily, we do up to 25 flexible cystoscopes. So this shows you how simple this procedure is and how fast it can be done, only for the needing patient. The picture on the left is a rigid cystoscope. And the difference is it cannot be done under local. It has to be done under spinal or general anesthesia because it can be painful. And the difference is this rigid cystoscope is not only diagnostic, it can be therapeutic. So it has a channel. We can put in biopsy forceps, baskets, or we can fulgurate a bleeding vessel. So it can be used to treat the cause of the bleeding. And I'm going to show you now some cases who presented initially with microscopic hematuria. However, they were found to have an identifiable cause. So this patient happened to have a papillary bladder tumor. And this was discovered after working on a patient with microscopic hematuria. This other patient was found to have microscopic hematuria, and he had undergone the workup and a CT urography, which has a delayed phase, where the contrast is excreted in the renal pelvis, goes down the ureter. It showed a filling defect in the ureter. And a filling defect is because of a stone or a tumor. So this is a flexible ureteroscopy. We started at the renal pelvis. This green structure is the guide wire. And we're pulling back the flexible ureteroscope in the ureter. And you can see here what we identified in imaging. We can see it here just for confirmation of diagnosis, is a papillary urothelial growth in the mid-ureter. It was biopsied, and it came back as a malignant urothelial carcinoma of the ureter. This patient had a nephroureterectomy, which is a radical treatment of this malignant disease, and the patient is cancer-free now for 4 years. So started with microscopic hematuria, ended up with a radical surgery, and the patient is cured. This lady had microscopic hematuria, and the doctor who worked this patient up did an ultrasound showing this large mass. Now, important to point out here is the microscopic hematuria was not caused by the mass. The mass was an incidental finding in a patient who had microscopic hematuria that was secondary to UTI. Why am I mentioning this? Because if you have an identifiable cause of the microscopic hematuria, and you decide to work up the patient, you don't do the workup halfway. You have to do the full workup, which includes cystoscopy, urine cytology, and imaging study. This patient had hematospermia, so blood in the semen. And we work up patients with hematospermia the same way we work them up for hematuria. So after workup, this patient was found to have prostate cancer and had a radical prostatectomy. Now we move from cancer into more benign causes. This patient had some pain, flank pain, with hematuria and the urinalysis microscopy, and he was found to have a bladder stone. This is how the bladder stone was identified. It was at the opening of the ureteric orifice, and this stone was fragmented using laser. I'm going to show another video of a patient who had a stone in the renal pelvis. You see here, this is after fragmentation of the stone using the laser. This is the surgeon maneuvering with the flexible ureteroscope within the renal pelvis, going into the different calyces. You can see here all these crystal-like particles, the remains of the fragmented stone. All these were patients who presented with microscopic hematuria. What about the patient who presents who is on anticoagulation? Is the approach to him different? I get asked a lot, if the patient was on anticoagulation, then the patient should be dismissed after controlling his anticoagulation status. I would argue against this, because the anticoagulation may have unmasked a hidden GU malignancy. So these patients get worked up the same way we work up a patient who is not on anticoagulation. In addition, I just touched on this topic. If a patient was identified to have a medical disease as a cause of the microscopic hematuria, manifested as renal insufficiency, hypertension, the presence of dysmorphic red blood cells in urine, red cell casts, or proteinuria, you should complete the hematuria workup. So this patient should get a cystoscopy cytology, upper tract imaging, in addition to the medical workup of this renal disease. Now, what if the microscopic hematuria was symptomatic? The workup is the same. The only difference is in the presence of symptoms, the likelihood of malignancy is higher. Symptoms may be dysuria, frequency, urgency. After you treat the underlying cause, let's say it is a documented, culture-proven urinary tract infection. You treat that cause and the patient still has dysuria, doesn't have hematuria anymore, has dysuria. This patient should be worked up because the most common presentation in patients with carcinoma in situ, which is an aggressive type of bladder cancer, present only with dysuria rather than hematuria. Now, since we are so worried about bladder cancer, why not screen everyone? It is the 6th most common diagnosed genitourinary malignancy in the United States. And it's the most common cause of microscopic hematuria. And the problem with it is, as I mentioned, it is a very expensive disease. The workup and management costs or puts a lot of burden on the healthcare system. So at any one moment, almost 3 million people are in follow-up for bladder cancer. And a lot of cystoscopies are being performed. There are no large-scale randomized controlled trials or screening trials to see if there is a benefit from screening for bladder cancer. However, evidence suggests that the costs and harms outweigh the benefits. But luckily, there is a lot of opportunistic screening events. So a lot of patients who present to their physician with a flu or with any other symptom, they undergo general workup, which includes a urine analysis, which may identify microscopic or hematuria. Now we move into the more ominous and more serious presentations. Gross hematuria. There is, in these patients, in 50% of them, there is an etiology. And in 20 to 25%, it's cancer. So these patients should be taken seriously. Assessment of these patients start by making sure they're stable, so ABCs. Are they hemodynamically stable? Are they in retention? Do they need to be hydrated? Are they septic? After evaluating and stabilizing the patient, looking for the cause, and the evaluation is like we do for microscopic hematuria. Now, if the patient with gross hematuria had a documented UTI, we treat the infection and the hematuria goes away. I would still be wary if there is only one risk factor for malignancy, being a male over 60 years of age. I would still send him for evaluation for hematuria. And this is the complete evaluation that we do. I personally do these investigations for every patient who comes to me with gross hematuria. Now we look at specific locations in the genitourinary system. So bleeding from the prostate is the most common cause of hematuria in males. It's either from BPH, prostatitis, or locally advanced prostate cancer. And it can range from self-limiting microscopic hematuria to severe hematuria requiring transfusions. And this is an algorithm that explains to us urologists what do we do for patients with this diagnosis of exclusion. I do the workup for the patient. I don't identify any source of the hematuria. Then I would say if he's a male, then it's most likely from the prostate. And for you to know, usually what we do for patients with bleeding prostates, if they are stabilized, we give them 5 alpha-reductase inhibitors, such as dutasteride and finasteride. They prevent the conversion of testosterone to dihydrotestosterone, and they decrease the glandular component of the prostate, decreasing the risk of bleeding. They work in 90% of patients, but the onset of work of these medications can take from 2 weeks up to 9 months. So we have to be patient with these medications. Bleeding from the urethra is not hematuria. It is urethroragia. And this is blood at the meatus in the absence of micturition, absence of initial hematuria, or a gynecological cause of this bleeding. All these patients require cystoscopy and a retrograde urethrogram because most likely it is caused by either a urethral stricture or a malignancy or a stone present within the urethra. And this is an array of causes of urethral bleeding, can range from trauma infections and STDs, malignancy, stones, and so on. In females specifically, they can have urethral diverticulum, and this is a chronic cause of urethral bleeding and usually requires surgical repair. Retrograde urethrogram is by injecting a contrast retrogradely, and this will show if there is a filling defect, stricture, or any pathology that can be corrected as a cause of the hematuria. Now, moving higher up in the urinary system, there is a long list of causes of upper urinary tract causes of hematuria. Can range from surgical to medical. And medical causes of hematuria can be glandular or tubular interstitial. You probably know more about this than I do, but the only important point I would stress here is even if you identify a medical cause of the hematuria, the patient should undergo the full workup just to rule out a concomitant cause of the hematuria. So what have we done here in Kuwait? Back in 2015, a committee was established and headed by the Undersecretary. The members of the committee were from primary healthcare, urologists, radiologists, radiation and medical oncologists, and it combined a screening program for prostate cancer and early detection program for bladder cancer. And it started as a pilot project, including Al-Asma and Hawali. An algorithm was distributed, and this was constructed back in 2015, and it was based on the older guidelines. That's why it says 2 out of 3 samples, but now we work up after the first sample of positive microscopic hematuria, and it explains what to do for the patient and when to refer to the urology clinic. I would add to this algorithm knowledge of the risk factors for genitourinary malignancy, and if it's there, you should refer the patient straight away. We have conducted lectures, we did practice on mannequins, and we started this pilot project since then. So, take-home message, you have a crucial role in managing these patients, speeding their diagnosis, and avoiding missing an important disease. At the same time, we don't want to refer all patients with hematuria. This will create burden on you and on us as urologists. Thank you.
Thank you, Dr. Saad, for the excellent lecture. Everyone is thanking for the nice talk. We have quite a few questions. First of all, can you please explain the reflux-induced hematuria in children?
I'm sorry, I just couldn't hear the first part of the question.
Can you please explain the reflux-induced hematuria in children?
So reflux is a disease affects the pediatric population. Usually, it's diagnosed in their, early few years. It results in hydronephrosis, renal impairment, and it is graded according to how the reflux looks on ultrasound. We do renal scan. Hematuria is not the main presentation, but it's urinary tract infection. And the worry in these pediatric patients, they are not potty trained, so they're wearing diapers. So with the presence of urine and stool, this predisposes them to developing recurrent infections. Usually you put them on prophylactic antibiotics until they either grow out of the reflux or they need surgical fixation of this reflux by reimplantation of the ureter or injection of deflux, which promotes a non-refluxing valve mechanism at the ureteric orifice.
The second question is about a 70-year-old lady with asymptomatic microscopic hematuria, 3 to 5, for the past year. She's non-smoker. What's her risk of malignancy?
So if I go back to the algorithm, she's over 70, she's a female, and I wouldn't list her as a high risk. She would be in the intermediate or low risk. I would assume she has no smoking history, no family history of malignancy, and no other risk factors for malignancy, exposure to radiation, chronic indwelling Foley catheter, and the other risk factors. So I would make sure that there is no benign causes of the hematuria, treat it, and if it disappears, I would repeat it again. These patients usually are old, menopause causes dryness at the introitus, managing them with hormonal topical therapy, making sure they don't have constipation before jumping and doing really invasive workup for the hematuria.
Thank you. The next question, since benign prostatic hyperplasia is a common cause of hematuria, will we send any patient over 50 with BPH to be followed up in urology with hematuria?
So I'm really glad someone asked this question. One of the take-home messages is you don't have to send this patient. Microscopic hematuria, if it's a diagnosis of exclusion, meaning that the patient was already worked up, you cannot say the hematuria is caused by BPH unless the patient was worked up by a urologist, ruled out all the other causes, and labeled him as someone with microscopic hematuria because of BPH. So if the patient presented for the first time with hematuria, and you think that there might be risk factors, send them to us. We work them up. Then we can send them back to you saying, well, I did the full workup, there's no malignancy. I think the cause of the bleeding in this guy is BPH. I would give him 5-alpha reductase inhibitor, and if he comes back after a month with microscopic hematuria, I think it's too early to repeat the workup. I would probably already have given him an appointment in 3 to 6 months to see whether I have to repeat the workup or not. So do not refer every patient with microscopic hematuria labeled as BPH cause of hematuria.
Regarding children with hematuria, what are the red flags?
So hematuria is always a scary sign for the patient and for the physician. But the order of etiology is different. In pediatrics, I think probably less of malignancy, although there are reported cases. I've seen a case with rhabdomyosarcoma of the prostate in a 1-year-old. However, we think more of benign causes. So patients with posterior urethral valve, patients with reflux, patients with recurrent urinary tract infection, believe it or not, patients with hypospadia, with uncircumcised phallus, with phimosis. All these causes can result in hematuria. The bottom line is history, physical examination, making sure that there is no serious causes of the hematuria. And there is a cheap, non-invasive, no radiation test that can be done, which is an ultrasound. Most urologists are trained to use the ultrasound. And I'm sure pediatric urologists and radiologists can do an ultrasound just to make sure there are no serious causes. Pediatrics is a scary group of patients. You don't want to miss anything in these patients. Likewise, I say about young adults. I would hate to miss a kidney cancer in a 29-year-old. I'd hate to miss it in a 89-year-old. But the implications are worse in a younger patient compared to an older patient.
Thank you so much, Dr. Saad. We have a few more questions, but we've run out of time. Thank you so much.
Regarding our next presentation, comprehensive introduction to weight loss interventions, I would like...
Please accept a certificate of appreciation. Thank you so much, Dr. Saad.
Regarding our next presentation, comprehensive introduction to weight loss interventions, I would like to introduce our speaker today, Dr. Mohammed Jamal. Dr. Mohammed Jamal is an associate professor of surgery and the chairman of the transplant department at Kuwait University. He's a consultant metabolic and upper GI surgeon performing hepatobiliary and bariatric surgery at Jaber Hospital. And Dr. Jamal also is a founder member of Kuwait Surgical Society and started the liver transplant surgery program in Kuwait 2018.
I would like to thank the organizing committee for inviting me to give this talk. I'm not going to give the talk to let you know when to refer the patients, because with the advent of medications, you are able to treat patients with obesity yourself. So initially, I'm going to try to convince you that obesity needs treatment. Following that, I will introduce you to bariatric surgery, followed by endoscopic interventions, and that at the end, we will talk about the current medications. So we all know that the treatment strategies varies. We start first by behavioral interventions, then we progress to pharmacotherapy, and at the end of the spectrum will be bariatric surgery. In the middle between pharmacotherapy and bariatric surgery would be the endoscopic techniques. But obesity now, we need to realize that it's the worst disease humans have ever known. The first treatment for obesity is published. I mean, there are publications from the 60s of how to treat morbid obesity. And the first treatment strategy was admitting patients for 1 year in the hospital and monitoring them eating 800 calories per day. This didn't work. And with follow-up, we noticed that most of these patients will regain their weight. Humans, I mean, our genes, we have a certain age, but our genes have been living there for 1 million years. And in all these years, 95% of the time of our genes was spent as hunter-gatherers. So we used to not eat any meals for days and maybe run miles to hunt a rabbit or a small animal. So this is even before the advent of agriculture. So our genes do not recognize diet, they recognize it as starvation. And therefore, this is not going to work with morbid obesity. We brought that genetic pool in an age where you can live all your day with only 2,000 steps per day with a huge amount of calories. So the modern lifestyle is what bringing morbid obesity. By the year 2100, 70% of the world population will be morbidly obese. This is the biggest genetic challenge humans have ever faced. Talking about conservative management, this is a randomized controlled trial from 2008, showing you the different results with different diets. There are 1,000 diets because none of them work for morbid obesity. Again, I'm talking about morbid obesity, a BMI more than 35. So with 2 years, initially you will get about 7% total body weight loss. With even 2 years of follow-up, which is not a very long period of follow-up, most of this weight is going to be regained. And if we talk about the look-ahead trial, that the NIH spent $500 million on that study, and it randomized patients into 2 groups, a intensive intervention group and a group that had no intensive lifestyle changes. And in the lifestyle intervention group, in the look-ahead trial, the patients were seen almost 50 times per year, along with them adhering to a diet of about 1,200 to 1,800 calories per day, and they were all exercising of about 150 minutes. With follow-up, we see, so they followed the patients up for 10 years with again, you see a similar result. Within the first year, you get about around 7% of total body weight loss. And with follow-up, despite adhering to these lifestyle changes, most of the weight is regained. But I show this to my patients in the clinic. But doctor, what about the Biggest Loser program? This is a patient from the Biggest Loser, and this is before the program, and this is 1 year after the program. We have always known that when you diet, your metabolic rate goes down. This is a study that was done. I'm going to present to you a study that was done on the season 6 Biggest Losers participants. And it was published in Obesity. Obesity is it has an impact factor of around 11. They monitored their metabolic rate before the initiation of the program, during the program, and at the end of the program, and they utilized very advanced techniques to calculate the metabolic rate. They found that most of the patients lost mostly fat with an increase in their muscle, but the most important question was, if their metabolic rate goes down with dieting, will it remain down or does it go back to their initial metabolic rate? And this is a busy table showing that actually even after 6 years of follow-up, their metabolic rate is still down. all the participants regained all their total body weight that they lost. And what's worse is that their metabolic rate was down and remained down. So in essence, conservative management of morbid obesity can be detrimental in the medium and the long run. If we talk about bariatric surgery, there are two families of bariatric surgeries: a restrictive family, which includes sleeve gastrectomy, the band, and there is the malabsorptive family, in which we reroute the food and the enzymes, and the two famous surgeries are the Roux-en-Y gastric bypass, the classic gastric bypass, or the duodenal switch. Down in the endoscopic intervention group, now we have the endoscopic sleeve gastroplasty, in which we suture the stomach by the endoscope, and we also have the balloon interventions. In terms of the sleeve gastrectomy, it's a very simple procedure. We just reduce the size of the stomach by around 70 to 80%. The biggest problem in the long term will be the reflux. I will show some slides later on the complications of various bariatric surgeries. In terms of the classic bypass, we reduce the size of the stomach and we make two anastomoses, one between the stomach and the bowel and another one between the bowel and the bowel. And this is the one anastomosis gastric bypass, or the mini gastric bypass, that is gaining ground now. And in that surgery, we only make one anastomosis between the stomach and the bowel, avoiding the second anastomosis between the small bowel and the small bowel, but it requires that we make a very long stomach pouch. This is the SADI operation. You might start seeing these patients coming to you, and we started doing this in 2015 in Kuwait, and basically we make one anastomosis between the duodenum and the ileum, and we usually do it following sleeve gastrectomy. The endoscopic gastroplasty, the endoscopic technique that I was mentioning earlier, in which we go with the endoscope and suture the stomach. We usually reduce the size of the stomach by 50%. This is the MERIT trial published in The Lancet. It contained 209 patients, and the weight loss was around 12% at 2 years. So this is a comparison between various procedures. The endoscopic gastroplasty will result in around 15% of total body weight loss. The sleeve gastrectomy will result in around 25 to 30%, and the bypasses will result in weight loss between 27% to 35%. They all impact diabetes in terms of remission and resolution, and ameliorate obesity-related comorbidities. Now, it is a durable option. So bariatric surgery is a durable option. This is a study from the Swedish group published in the New England Journal of Medicine, showing that even with 15 years follow-up, you can still get a sustained weight loss in the majority of bariatric surgery performed. These are 4 studies showing the remission of type 2 diabetes following bariatric surgery. We can achieve up to 70% of remission, even with longer follow-up of type 2 diabetes. This is a study on the cardiovascular events. So bariatric surgery not only reduces the weight and ameliorate obesity-related comorbidities, but it also improves the life expectancy by reducing cardiovascular events and also reducing the incidence of cancer. The last study here is the Splendor study, which is very relevant for us in Kuwait. 95% of patients with liver fibrosis listed in our transplant list for liver transplantation are having their liver fibrosis due to NASH, which is the combination, which can result from the combination of fatty liver along with type 2 diabetes. So this study looked at 650 surgical patients and compared them to around 500 control and followed them with liver biopsies. In terms of patients who underwent bariatric surgery, there was a major reduction in cardiovascular event and mostly in liver fibrosis. The impact of bariatric surgery on the liver is even better than the impact of liver transplantation on the liver itself. Now, in terms of the complications, the short-term complications are leaks, 1 to 2%, bleeding, similar rate, DVT and pulmonary embolism is less than 1%, nutritional deficiencies are more common with the bypass group, but less common in the sleeve gastrectomy. Dumping syndrome can occur in any patient who undergo gastric surgery. Internal herniation is more common with the classic bypass. Marginal ulcer is commoner with the bypass patients, and gallstone disease. In terms of the nutritional deficiencies, it's very rare to observe nutritional deficiencies in a normal sleeve. It's more common to observe nutritional deficiencies with the duodenal switch, the SADI operation, or the bypass operation. Now, in terms of the safety, I just want to end up with 2 slides on safety before going into pharmacotherapy, which I think will be of interest to you. In terms of the safety of bariatric surgery, it's one of the safest procedures. I'm presenting to you data from 2008 to 2012. The safety is now even much higher. You can see common procedures performed in the United States, and you can see that the bypass, which carries more mortality than the sleeve, is even safer than a laparoscopic appendectomy and a laparoscopic cholecystectomy. This is another study showing that the bypass as well is, again, safer nowadays than a laparoscopic cholecystectomy or a laparoscopic appendectomy, of course, if performed by a specialized surgeon. In terms of the characteristics, there is a major change now. The previous guideline was from 1991, before the improvement in the safety of bariatric surgery, and it required that patients who undergo bariatric surgery to be having a BMI above 40 or a BMI above 35 with comorbidities. The new guideline from 2023, which will soon be implemented in Kuwait, it's not yet implemented in Kuwait, reduced the BMI to a BMI of 35 without comorbidities. Those with type 2 diabetes can be operated even with a BMI of above 30, and it gives a special consideration to Asian population, because we know that in the Asian populations, type 2 diabetes and its complications will be more common even with a lower BMI. The endoscopic techniques, balloons, one of the most widely used balloons that can be utilized also by the family physician is the ellipse balloon that does not require endoscopy. Patients will swallow the capsule. It will be converted into a balloon and will be excreted by 4 months. This is one of the first studies published by our groups. By our group, we compared those with a BMI of above 32 to a BMI of below 32. And you can see that even after 1 year of the excretion of the balloon, we can still get a maintenance of the weight loss of around 10%, especially in those with a BMI with a BMI below 32. Now, talking about pharmacotherapy, pharmacotherapy will give you results anywhere in between diet and exercise to endoscopic techniques. But with the advent of a newer pharmacotherapy, we are achieving similar weight loss even to bariatric surgery. In terms of the long-term anti-obesity medications, the oral medications used to give you a weight loss of around 4%. Liraglutide gives you, which is Saxenda, will give you a weight loss of around 6%. Semaglutide, Ozempic, or the trade name or known by the trade name Wegovy, can give you a weight loss of around 12%. Mounjaro or Zepbound can give you a weight loss between 18 and 22%. And the newest one that will be available probably in 2 to 4 years from now, retatrutide, which is a combination of GLP-1, GIP, and glucagon receptor agonist, can give you a weight loss of between 20 to 24%. So the liraglutide and the semaglutide are GLP-1 agonists. The tirzepatide, which is the Mounjaro, is a combination of GIP plus GLP-1. The retatrutide adds glucagon receptor agonist to GLP-1 and GIP. This is a summary of the weight loss that you can get with most of the current medications, and it can vary again between from 6% to up to 20% with tirzepatide 15 milligram. We don't know what is the exact action of these medications, but we think the most important site of action, especially for GLP-1 agonists, is the hypothalamus and the nucleus of the salivary tract. So obesity is a disease caused by the brain. The cooperation between the brain and the GI tract through the hormones and the afferent signals is what keeps obesity and keeps maintaining the set point. Your patients in morbid obesity, weight loss is possible. The issue is that their weight will be regained to their initial set point, that is the brain, that the brain is maintaining. The indications for pharmacotherapy will be a BMI of above 27 with any comorbidity, or a BMI of 30 without comorbidity. The best intervention for weight regain nowadays, I reduced my revisional surgeries following weight regain for sleeve gastrectomy, and I'm using mostly medications when somebody is starting regaining weight after bariatric surgery. And I think this is the best indication, weight regain post-bariatric surgery. Pre-operative preparation, so if you have somebody with a super morbid obesity, a BMI above 65, I would start the treatment prior to surgery. And in high-risk patients in renal dialysis or patients with liver fibrosis, in which you want to get them into the transplant list, I would use medications for those patients. Now I'm going to focus on studies on liraglutide, semaglutide, and tirzepatide. So in terms of the liraglutide, Saxenda, these are 4 different studies comparing liraglutide patients to a group of patients with conservative therapy. And you can see that in the placebo group or the conservative therapy group, the weight loss is around 3% comparing to 8% with the liraglutide. In terms of the semaglutide, this is the first study called the STEP 1 study, and after 68 weeks of therapy, the reduction in weight is around 15.6%. This is using a dose of 2.4 of Wegovy. So in the Ozempic, which is used for diabetes, the maximum injection that you can get is 1 milligram, but in the Wegovy, you can go up to 2.4. So these patients who started 2.4 or were titrated to 2.4 therapy achieved 15% of total body weight loss within 68 weeks. This is another study in which all patients were giving semaglutide for the first 20 weeks, and then they were randomized to placebo or a continuation of semaglutide. So the patients who were randomized later to placebo regained most of the weight lost. However, patients who continued in the therapy continued to lose weight. So we know that by stopping the medical therapy, most of the weight will be regained immediately. In terms of the tirzepatide, the first study available is the Sermont 1 trial, and this is impressive. In terms of the average body weight reduction, with only 5 milligram of tirzepatide or Mounjaro, the weight loss was around 15% of the total body weight. When you go to 10%, it's around 19.5%. 15 milligram was 21%. So you don't need to escalate the treatment with the Mounjaro for weight loss. You can maintain the patient on 5 milligram, and if you want to escalate it, 10 milligram of Mounjaro will give you very similar weight loss to 15 milligram. In terms of participants achieving more than 10% of body weight reduction, 84% of patients who received 15 milligram of Mounjaro achieved that weight loss. And if you look at the extreme weight loss, more than 20%, you have 57% achieving a weight loss of more than 20% with Mounjaro 15 milligram. The complications will include nausea. These are the complications for GLP-1 agonist and GIP, nausea, vomiting, change in bowel habit, pancreatitis at around 1 in 1,000, and abdominal pain. Abdominal pain is more common in Mounjaro in comparison to semaglutide. The tolerance is much better in the weekly doses, the semaglutide and the tirzepatide, in comparison to liraglutide. Liraglutide tolerance is less than of that of Mounjaro and tirzepatide. We shouldn't give GLP-1 agonists in patients with medullary thyroid carcinoma or family history of MEN syndrome. So in summary, obesity is a real disease. It's a chronic disease. We need to work in a multidisciplinary system to achieve the best results. I think there is a huge role for family physicians in the treatment of obesity, especially with the creation of all these medications. There are about 30 new medications in the pipeline that will come in the next 10 years. I will be happy to take questions.
Thank you, Dr. Mohammed, for your informative presentation. It was really interesting. I have a lot of questions for you, but we will keep on time. I will start with a question. Given the possible morbidities, B12 deficiency, dumping syndrome, associated with bariatric surgery, what would you consider as a serious weight loss attempt before considering surgery?
So the serious weight loss attempt was a creation of insurance companies in the US. Back in the time, most of the insurance companies required those serious weight loss attempts. This is not scientific at all. And nowadays, most of these companies that used to require those serious attempts dropped it, because we know that even with serious attempts in BMI more than 35, I have shown you several randomized controlled trials. There is no single randomized controlled trial showing that conservative therapy can work in morbid obesity. And there are studies showing that most of the patients who go for surgery have attempted 7 times a successful weight loss attempt. So 98% of the morbidly obese do not come and knock my office. They come to you, 98%.
Right.
Because they believe that this is their own personal problem, and they believe that surgery is not the treatment. By the time they consider surgery, they have done a lot, and they really did their best prior to reach surgery. The vitamin B12 deficiency is very rare with sleeve gastrectomy, especially with follow-up. Follow-up is very important. We every 3 months we do a complete vitamin check, and they have to do it once a year. So if you receive any patient who did bariatric surgery and have not done any vitamin level, they should do it once yearly. They should remain on a specific formulation. There are certain formulations given for patients with bariatric surgery in terms of vitamins, and if they do that, these side effects are very low. Dumping is lower with sleeve gastrectomy. You will notice it more during Ramadan at the time of the break of the fast, and they will require nutritional support and nutritional guidance to avoid that. I don't see this as serious attempts. You need to know that by the age, if your age is 25, your BMI is above 35, you have lost 15 years of your life. Mm-hmm. So if you have genes that will expose you to cancer at the age of 90, but you get morbid obesity, you might get that cancer at the age of 70. If you have genes that are bad for your heart, you might get your MI at the age of 60, but if you are morbid obese, you'll get it at a lower age. Obesity is creating new diseases. When we were in medical school, we didn't know that obesity will cause so much liver fibrosis. When I did my transplant fellowship, NASH or fatty liver was the 5th cause of cause requiring liver transplantation. Now it's the #1 reason for liver transplantation all over the world. So we are treating a very peculiar and difficult disease to treat.
My next question, I think it's partially related to what you answered before, but at a level of primary care, we saw a lot of patients undergo bariatric. Then they relapse, again their weight and gaining weight again. How to prevent this? And what's the role of primary care post-bariatric?
So I think most of the bariatric surgeries done in Kuwait back in between 2009 to 2015 were done without a multidisciplinary approach. Nowadays, most of our clinics and in the government, we work together with an obesity medicine specialist and a nutritionist, and we enforce the follow-up with the patients and the importance of exercise and the nutritional follow-up to avoid weight regain. Weight regain is about 10 to 20% with bariatric surgery with 10 years of follow-up. Again, with medications, what we are doing now is we are starting medications early. So let's say I have a patient with a height of 170, weight 100, weighing 110, went down after bariatric surgery to a weight of 70. And at follow-up, let's say at 2 or 3 years, I start noticing that his weight is 80. So 10 kilos more than the lowest weight reached, then we can start medications. And I think this is something that can be done at the primary care level with time.
Another question regarding the morbid obesity, you advised them for bariatric surgery, all of them. The question that with the new medications, you recommend to use them before or just go directly?
So the issue with the medications is the weight regain after stopping the medication, the cost and the availability. I think the medications are important for those in the range of BMI between 30 and 35. Any chronic disease is a progressive disease. So if you have a BMI of 31, we know that with time you have a very high risk of progressing to a BMI of above 35. So I think the role of medications will be important in preventing patients with early obesity to get into morbid obesity. But I don't think it's the best treatment for morbid obesity, because by stopping it, we know that most of the weight will be regained. So I believe that a BMI of above 35, especially with previous serious weight loss attempts, should undergo bariatric surgery, especially with the high safety profile that we have now. A sleeve gastrectomy is carrying now a major complication rate of below 1 in 300, which is, again, safer nowadays than a laparoscopic cholecystectomy.
Thank you. Now, Dr. Adina. Dr. Adalia.
Okay, so coming to the end of day one with the last topic of the lecture series. It will be about the spine, the unexpected cause, with Dr. Wael Saad Al-Asak. Dr. Wael has a PhD in physiotherapy. He's the CEO of Active International Group and Active Physiotherapy Center. He's the former chairperson of the physical therapy department at Kuwait University. He's a certified trainer in TOYF, Business International, and a practicing physiotherapist and consultant member of American Physiotherapy Association and member of Kuwait Physical Therapy Association. So, Dr. Wael, the floor is yours. You can start.
شكرا. السلام عليكم ورحمة الله. Is this supposed to be? Okay. ممتاز. السلام عليكم يا جماعة. Before I start, ممكن توقفون? Can you stand up for me, please, just for a second? بس أوقفوا شوي. أوقفوا شوي. الله. أوقفوا. كل واحد يوقف على أطراف أصابعه. Just stand on your toes. Just on your toes. Do it 3 times. Try to reach for the ceiling. That's good. Let's sit down. Thank you very much. It's good to be at the end. What I'm going to present today is a collection of my experience when I was at Kuwait University. I worked at Kuwait University for about 11 years. Then I said, let me move on I don't know, I moved or they kicked me out, I don't know. So I moved to my own practice, and we started a clinic called Active. Active means using activity-based intervention, and the patient is active with us during treatment. That's why we called it Active. So what I'm going to present to you today is a collection of experience through what we've been teaching at Kuwait University at that time, and things that I've learned during my practice. We already served about 37,000 patients in our clinic, so we learned a little bit. So I'm going to present to you a few things that I would like to share with you about some cases that you're seeing in your clinic, and sometimes those patients are not really being directed appropriately to the professional who can help them, and whether it's within our medical staff or other professions, so that we can better serve our patients. I started with the spine because today we are seeing a lot of patients having injuries related to the spine, and I called it spine injuries, the unexpected cause. Some of you already know this cause, and some of us need to look at this cause. So by the end of this presentation, hopefully, you'll be able to identify some common spinal related injuries, related causes, or relate causes to some current spinal injuries to a specific cause. And hopefully we can identify together the unexpected cause and identify the aims of physiotherapy in our intervention with these cases. Before I start on, I'd like to hear from you, what are the common cases that you are seeing in your clinic regarding spinal injuries? نسمع منكم. Back pain, بعد. Sciatica, hello. Scoliosis, stiffness, بعد. You have more than just the lower back in the spine. We have something up there. خلوني أبدأ question ثاني. كم واحد فيكم, how many of you have neck pain? خلينا نشوف ايدكم. يا سلام. راح نوزع عليكم كروت العيادة عيال. How many of you have low back pain? شوفوا القاعة. So it's really common. It's really common to see people with low back pain, common to see people with neck pain, and sometimes we don't know what's the cause. وبعض الناس نسمع عندهم I have chronic low back pain, I have chronic neck pain. I don't believe that we have chronic low back pain, but have chronic reason that is not identified. That's why we cannot treat the low back pain, or we cannot treat the neck pain. So, let me get your help. We see some patients with low back pain, but this pain while they are sitting, but there is no radiating pain or radiculopathy to the lower limb. What might be the cause? Low back pain in long sitting. Once they get up, walk, they have no problem. What could be the cause? Posture. Okay, posture, but what's the underlying impairment? The seats, what the underlying impairment within the spine? What's taking place? Most of the time, people sitting with posterior pelvic tilt, so there will be more stretching of the soft tissue, so there is strain of the lower back. Once they get up, they get the normal lordosis, they get the soft tissue at their normal length, so there is no pain. مع هذول الناس شو نحتاج نسوي؟ Correct the posture. زين؟ وبالتالي تنتهي المشكلة. Let's go back one. Low back pain after long standing. بعض الناس يقول لو وقفت فترة طويلة يصير عندي low back pain. لما أقعد ما عندي مشكلة. What could be the cause? muscles. حط ايدك على ظهر المريض راح تشوف عنده increased lordosis. increased lordosis. لما يوقف لأن عنده shortness في الاليوسوس muscles, once they stand up they pull the spine forward. بعدين يصير في compression على الفاسد joints. So the longer they stand they have pain. الكي يقول لك لما أقعد ينتهي. لما بند أوفر ساعات يكون بالسوق ولا كذا يقول بس أسوي بهالحركة يروح الألم. It's very simple. They have increased lumbar lordosis. Sometimes people have radiating pain to the lower limb in standing. أحياناً both sides. شنو السبب؟ Sometimes we see those people having listhesis. In standing, there is instability of the lumbar spine, so there will be anterolisthesis, there will be compression over the nerves, وبالتالي ممكن يكون عندهم هذا النوع من الألم. Sometimes we need to get deep with some of the patients to know, is this pain intermittent or is it continuous? 24 ساعة ولا in certain positions? These are very important tools that we have to have while trying to diagnose the patients. Some patients have gradual onset of the pain, and some people have sudden onset. بعض الناس لما يكون referred ويقول إنه عنده osteoarthritis، فبالتالي عنده الpain because of this or that. إذا كان gradual فممكن يكون فيه osteoarthritis. بس إذا كان sudden ونشوف في الإكس-راي إنه يكون في عنده degeneration. بس it's a sudden problem. يقول ما كان فيني شيء، رحت مناسبة وصار لي شيء. فهني most likely it has nothing to do with the OA. So it's very important to look deeply at the causes so that we can properly diagnose the patient. ممتاز. ساعات يكون localized، ساعات يكون at certain positions. الآن it's very important to look at in the process of diagnosing, to look at these important points. Is it sudden onset, has to do with an accident, أو في مناسبة واحدة راحت العرس سوت اللي تقدر عليه ويات عندها pain. It's most likely has to do with this incidence. خلونا نشوف هذا. لا نروح نطالع مثلا بعض الناس it's very interesting sometimes حتى بعض الناس they relate wrongly to old age. ها؟ ليش عندك ألم الظهر؟ ليش تآكل؟ قال والله لأن العمر كبرتي. زين بس اللي فوقها مو متآكلة. نفس العمر. زين فلذلك we need to know these things. بعض الناس يقول والله من زمان عندي الألم يروح ويرجع. This is very important points to bear in mind while trying to diagnose the patient. Ask the question where is the pain? بعض الناس يقول ظهري يعورني. لما يقول ظهري يعورني احنا وين نفكر؟ بالظهر. ايش نكتب؟ low back pain. لما اقول له وين يعورك حط ايدك يقول هني. هذا الظهر. completely different diagnosis. واحدة من البيشنتس جاتني قالت لي دكتور أنا قالوا لي إني أبدل ركبتي اليمين. أوكي شفت الإكس راي فعلاً في degeneration في ركبتها اليمين. قلت لها زين طيب أختي وين العوار؟ قالت لي في ركبتي اليسار. Some of our team members are treating the X-ray, not the person. Shift patients have advanced degeneration وما عندهم pain. يصلون على الأرض وما عندهم مشكلة في الدرج. Advanced degeneration. So ask the patient, where is the pain? Show me. Most of the time, you see the pain related to soft tissue, not on the joint surfaces. Mostly on the soft tissue. نشوف في التendons, نشوف في ligaments, نشوف في muscles. Most of the time, where the joint spaces are so decreased, but there is no pain within the joint. So it's very important to know some of these issues. Please palpate. You, as a doctor, please palpate so that you can feel for yourself where is the pain. ساعات بعض البيشنتس يقول تحت. وين تحت؟ خلوني ألمس، خلوني أشوف. فبالتالي we can localize where is the pain. Is it related to the tendon? Is it inside the joint, outside the joint? So that we can reach up a proper diagnosis. ساعات يقولنا patients وهذه اليوم currently seen يعني almost not almost it's every day. ساعات يكون معي يعني 3, 4, 5 patients عندهم these common symptoms. Or see for yourself if you have these symptoms. Sometimes they come as clustered together. يكون عنده neck pain, headache associated with headache, dizziness, blurred vision, tinnitus, inability to focus, nausea, forgetfulness. أمس كانت عندي واحدة تقول وايد أنسى. Brain fog, reflux, cardiac arrhythmia, swallowing problems like hard to swallow sometimes or choking, change of voice, breathlessness, general fatigue, and sometimes others. لما أسأل بعض البيشنت عندك هذا؟ إيه. كم واحد فيكم عنده 3 or more of these symptoms? Welcome to the club. What's the diagnosis? Depression, anxiety, شنو؟ lack of sleep. حلو. بعض الناس يقول أنا أنام وما عندي مشكلة في النوم وأنا happy person but still have a problem. هذه اليوم أصبحت معضلة في التشخيص. وبالتالي a lot of patients, if we don't know what's the يعني المشكلة إنه we run up all the tests, all the x-rays, all the MRIs, everything is normal. We don't see any problem. بعدين شو يقولوا له؟ You need antidepressant. روح مستشفى الطب النفسي. بعض البيشنتس يقول والله دكتور أنا دخت وطحت تعورت يعني مو يتهيأ لي. وبالتالي again, this is something you will see and you will see a lot. And in the future, we will see a lot. We used to see it with people at older age. We are seeing it with people younger. وفي الفيوتشر راح نشوفهم أكثر وأكثر. شو المشكلة؟ ساعات يكون عندنا بعض الناس عندهم Ehlers-Danlos syndrome. Some people have KRE, ناقص الآي هناك. KRE malformation or acquired. CSF blockage or restriction, sometimes tension in the spinal cord. اليوم بعض الناس يقعدون ما يدشون يتصفطون. The spinal cord cannot be stretched beyond limits. وبعدين يسوي لنا damage within the spinal cord ويعطينا neurological signs. فهذه واحدة من المشاكل. Upper cervical instability or craniocervical instability, CCI. Vagus nerve injury. Vagus nerve, vagopathy. Vagus nerve does a lot to the body. That's why it's called vagus, the wandering nerve. العصب الحائر. هو مو حائر بس محيرنا. وايد محيرنا لأنه يغذي وايد شغلات. فأني injury to the vagus nerve or degeneration of the fibers of the vagus nerve يعطينا مشاكل الدنيا وما ندري ليش. It supplies the heart, supplies the lungs, supplies the gut, supplies يعني you name it. وبالتالي any injury definitely it will affect what it supplies. We have to understand first that these are real symptoms. مو ان البيشنت يتهيأ له. واحنا احيانا ساعات نخطئ في الميديكال فيلد احيانا اذا انا ما عرفت اذا مشكله البيشنت انت فيك انت كذا لا انا ما عرفت بس. وبالتالي it's a real thing. Choose the proper diagnostic tool. Sometimes X-ray will be enough. Sometimes we need an MRI. Sometimes we need Doppler, depending on what we are testing. Choose the right position. أحياناً الposition اللي احنا معروف standard, it's not enough. Usually when you take an MRI, خلينا نشوف هني, you take an MRI, you put the MRI in this fashion and you try to read it. خلينا نحط ببالنا إن ال MRI was taken in supine. A lot of symptoms people will have when they bend over or sit down. In supine, كل شيء يرجع لحالة قريبة من الطبيعي. We read it wrongly. That's why today there is an upright MRI so that we can look properly at the position of the patient. And we ask the patient to sit with forward bending, neutral, and with extension so that we can see the difference. Look at here. The compression or the invagination at the base of the medulla in supine and in upright MRI. Is there a difference? There is a difference. And this is the area where the roots of the cranial nerves comes out. So when there is compression, there is malfunction of those nerves that come from there. What would these nerves supply? It will be affected. So that's why it's very important to know which position that is appropriate for which patient. And this is very important. We see some patients with descent of the tonsil. This is the pointer. Descent of the tonsil, like in Chiari malformation, and sometimes in acquired ممتاز. You see here, there is descent of the tonsil. Sometimes it's because of malformation, and there are some acquired. شلون ممكن نحصل عليها؟ تخيلوا ان عندنا the spinal cord is part of the brain, but it is outside of the brain. هذه لعبة حلوة. Okay. You see, إذا صار عندي bending over, well, spinal cord cannot be stretched. Sometimes it pulls this out within the foramen magnum. ويصير عندي compression. وبعدين يصير عندي blockage of the CSF. CSF has to go around the brain and the spinal cord. لما يصير squeezed ما يمشي راح يصير retention في البرين فبالتالي يزيد الانتراكرانيال بريشر الحين يعطينا كل الامور اللي مساعد تكلمنا عليها. وبالتالي this is something so serious and we have to look at it this way. شوفوا هذه الMRI, very interesting. It's not a matter of just disc bulge. It is obstruction of the CSF. Okay. What is common about these conditions? This is the unexpected cause. اللي هو, there is mechanical problem. Most of these cases, they share the common cause, which is the mechanical problem. Most of our diagnosis will be based on looking at chemical point of view, not mechanical point of view. And there is a lot of our patients, their problem will be solved if we try to look at it from biomechanical point of view, not just chemical point of view. But we have also to take care that there is relationship between the chemical and the mechanical distortion that takes place within our spine. These are some of the movement that we see. There is tension. A lot of people, because they are sitting, مثل ما بعضكم الحين قاعد وبالتالي قاعد slouched وماسك تلفون. Think of the spinal cord. ايش كثر هو قاعد ينسحب. This is tension, compression. يكون عندنا shear forces مثل لما يكون عندنا listhesis. لما يكون عندنا bending, torsion, and these kind of things that has to be seen when we analyze what's going on with our patients. So the mechanical problems can lead to chemical problems. إذا صار عندي injury to the vagus nerve because of the listhesis or because of the instability. عندنا 100,000 خلية عصبية تتعامل مع 3 ملايين داخل الدايجستيف سيستم، 1 إلى 3000. فإذا صار في عندي أي degeneration في الفيجاس nerve, do you think that it will affect the gut and the system, the digestive system? فعلشان كذي لما نشوف نطالع أحياناً إن everything is normal here, but what's supplying it is the problem. فعشان كذي ممكن يكون عندنا mechanical problem that's causing this. أحياناً يكون عندنا arrhythmia that is not caused because of the heart problem، لأنه يحطوا له كل شيء ويشوفون الانزيمز، يحطوا له الهولتر ويطلع everything is normal، وتكون مشكلة في النك. أحياناً بعض الناس يكون عنده breathing problem restricted because of the neck، وبالتالي هذه من الأمور اللي هي تحتاج إن احنا we look at it from mechanical point of view. Sitting posture, this is very important. Long time tensile forces, repetitive stress. يا جماعة بس سؤال واحد، كل واحد فيكم يطالع السقف، طالعوا السقف، طالعوا فوق، look at the ceiling. حلو تمام. الآن كم مرة في اليوم تطالعون السقف؟ كم مرة في اليوم تشندسون؟ Repetitive stress. Think of the soft tissue. How many times we flex our neck for how long? تخيلوا ligaments at the posterior aspect of your neck. Think of the atlantoaxial joint. Think of the craniocervical joint. هذه اللي تحركنا كذي واحنا قاعدين. Repetitive. These kind of the problems that we see. أنا بحاول أخذ بسرعة أساس أسمع بعض الأسئلة عندكم. No medications will be successful in treating mechanical cause. Mechanical cause has to be treated mechanically. As a team, we have to work together to know what intervention is suitable for what time or which patients with which team member. لو سألتكم منو أهم team member عندنا غير في الميديكال؟ ها؟ فيزيوثيرابيست. يا سلام. Awesome. لا للأسف. The most important one is the first member to see the patient. I don't care who he is or who she is. يمكن البورتر يكون أهم مني لأن لاحظ شلون ينزل من السيارة، لاحظ شلون يقعد، يمكن داخ عنده وهو ينزل فيقول لي. He is the most important person who saw the problem, who saw the patient. يمكن يكون the primary care physician, family physician. يمكن يكون the neurologist, يمكن يكون the cardiologist. I don't care. The first one who identifies the problem, his and her responsibility is to properly direct this person to the appropriate professional. لأن يجونا بعض البيشنتس مساكين دايرين الدنيا كلها، ليش رحت حق هذا؟ مو شغله، والله ما أدري، أقع ماسك ملفه ورايح من وكا. No. The first one is the most important member because he or she will save the patient the hassle. Aims of physical therapy intervention. If we ask, can physiotherapy be effective in treating these causes? Based on my experience in the clinic, and we are seeing lots of patients, and we are looking also at systematic reviews. Anybody who's interested, I would like to probably send to Dr. Adalia the references on that, and you can send her an email. It's my fault I did not include that in the presentation, but I can send it to anybody who's interested. The aims in physiotherapy, we can make a difference with lots of patients. I cannot say all patients, but lots of patients. And we've seen that sometimes within a week, within a week, we've seen some differences because, again, we brought stability to the unstable joints. So the aims of physiotherapy is as follows. We have to encourage patients to sit properly, to sit in the proper posture. اليوم قاعدين نشوف ناس وايد at younger age قاعدين بهذه الطريقة. يا هال صغار. Because of the introduction of the mobile phones early in their age, راح نتوقع أن يكون عندنا حالات كثيرة نفس هذه. 11 years old عنده instability. دوخة. واحدة في الثانوي تقول دكتور I'm genius. الحين ما أقدر أركز. lack of focus. أنسى وايد. فهذه كلها حالات قمنا نشوفها وراح نشوفها وايد في المستقبل للأسف. Use proper supportive equipment if needed. شو رأيكم بالكرسي هذا؟ ها؟ حلو؟ ممتاز. ساعات بعض الناس هدية حق الوالد والوالدة وقاعدين ها. This is the worst. We'd like to move to something stable so that we can support our back, because most of these fluffy sofas, they enforce the posterior pelvic tilt. They force the posterior pelvic tilt. وإذا صار بعد مع مدة الريل يا سلام يعطينا مشكلة في shortness of the quads muscles وبعدين نسمع أصوات الركبة تحك وبعدين يصير عندنا مشكلة في قعدة الصلاة صعدة الدرج إلى آخره. فاللي يبيع منكم هذا راح يخسر ترى. We can use back support. زين. We restore the stability of the joints. Restoring the stability of the joints. Most of the problem with these patients is the instability. So we'd like to restore the stability, restore the proper spinal alignment. وايد ناس يصير عندهم زيادة في تقوس الظهر what has to do with long time sitting in this position. فبالتالي يكون عندنا shortness في الإليوسوس attached to the back لما نوقف ما فيها طول كافي فبالتالي تسحب العمود الفقري فيصير عندنا increased lordosis. Restoring the proper alignment will save a lot of the hassle to the patients. Restore functional muscle length and strength. Encourage positive healthy lifestyle. كم واحد فيكم يحب يقعد يحط ريل على ريل؟ For long time. ها؟ هذه ما عندي مشكلة إذا عندكم the activities that can restore the length of the muscles. بس إذا نقعد وايد ريل على ريل in lateral rotation يصير عندنا shortness في المسل هذه weakness وبالتالي يصير عندنا اللي هو lateral shift of patella وبالتالي يصير عندنا احتكاك degeneration pain and you name it. لو مثل أول نقعد نبوبز ونقوم وكذا ها ما عندي مشكلة. لكن إذا قاعدين طول الوقت فبالتالي we are not really working the muscles that are responsible on bringing back the proper alignment. فالقعدة المناسبة move on. خلونا نشتغل واحنا واقفين. ليش نشتغل واحنا قاعدين؟ تبي تقرين ارتكل؟ اوقفي امشي. ها؟ ساعات في بعض اماكن العمل حطي لك ستيشن مثل هذه اوقفي. اوقف مع البيشنت واخذ وعط. حاول انت تطلع برا الغرفة تنادي احد. move. Let's move on. اليوم عندنا مشكلة في الموفمنت. تدرون يا جماعة مساعد دكتور جمال تكلم عن الأوبيسيتي. تدرون أن the fourth leading cause of death today is physical inactivity? The fourth leading cause of death is physical inactivity. كم ساعة نقعد في الدوام؟ نقعد في السيارة. وصلنا البيت خالصين. شو بنسوي؟ نقعد. خلصنا من القعدة بنروح نطلع مول ولا whatever. وين نروح شو نسوي؟ نقعد. فالقعدة الطويلة physical inactivity. Remember, your muscles, use it or lose it. Use it or lose it. فهذه من الأمور اللي نحتاج إننا نسويها. Be as much happy in your life with what you're doing and make it as a lifestyle. يعني يونا بعض البيشنتس مثل ما قال مساعد الدكتور إنه ممكن الواحد يتحسن وبعدين يرجع مرة ثانية يصير عنده الآلام. ليش؟ لأنه ما صارت لايف ستايل، صارت تريتمنت فور بين مثلا، راح البين خلاص وقفت ورجعنا مرة ثانية.
دكتور وائل.
Let me stop here.
Yes, because we have time issue also. And
Let me stop here.
Yeah, الجماعة تفاعلوا معك. We received a lot of questions, so if you just.
Let me stop here. شكرا يا جماعة.
أمانة يعطيك العافية، كلنا استمتعنا واستفدنا. And I have a question from one other colleagues تسأل عن حزام الظهر. Is it useful في حالات اللوردوسز؟
شكرا. اللوردوسز الحزام ممكن يصلح حق مع بعض الناس اللي هم خاصة الحزام اللي هو السبورتيف حق الناس اللي عندهم الاستيسز، فيعطينا شوي ستابيليتي لكن ما يعالج المشكلة. المشكلة لها علاقة في shortness of the muscles والإليوسوس muscle قوية جدا، عشان كذي تعطينا instability وهي تسبب لنا الاستيسز. فإذا حطيت الحزام ما راح يسوي شيء إلا أن الإنسان راح يقلل الأكتيفيتي وبالتالي it leads to weakness of the muscles. الحزام اللي فوق مال الشولدرز نعتقد انه هو يعدل البوستشر، بس ما يعدل البوستشر، لانه لما نلبسه لازم نسحب بقوه فيعوركم من هني بالبكتوراليس مسل، والمشكله مو فوق. انا ممكن البسه واكون قاعد كذي ما سوى لي شيء، المشكله في الباك. الا ان تلبسون الحزام اللي هو فيه صياخ من ورا، هذا خلونا حق الفراكشر اللي معاه فراكشر، بس ما ينفع. Let's use the muscles instead.
We received also questions with regards to the benefit of yoga and acupuncture in patients who have disc prolapse. So what do you think, Dr. Wael?
اليوغا في عندكم أكثر من 120 pose. I don't know which one are you going to do. Usually with disc prolapse, أول شيء خلينا نحط في بالنا يا جماعة it can be healed. It can be healed. بعض الناس يقول disc prolapse cannot be healed. It can be healed without surgery. وشفناها بالإيفيدنس في الريسيرش وفي الكلينيك وقاعدين نشوفها. لكن عندنا مشكلة إذا كان البيهيفير مستمر راح يكون الأوتكم مستمر. فبعض الناس يكون عنده the same behavior so we won't see any change. فممكن إن بعض التمارين خاصة اللي فيها extension لأن راح تشغل لنا شغلتين، تشغل لنا اللي هي المسلز وخاصة الانترسباينوس مسلز اللي هي مسل تساعدنا نقعد against gravity، وهذا البوزيشن الطبيعي اللي هو راح يحفظ اللوردوسز ويترك مجال للديسك to be healed.
Okay. سؤال شخصي مني أنا دكتور. Now because we spend most of the time sitting actually. So يعني if we want to improve our sitting posture or our standing posture, يعني advice also we can offer for our patients or for our beloved persons. شنو الادفايس اللي عادة how do we improve the sitting or the standing posture?
أول شيء إن إحنا ما نقعد فترة طويلة. We don't sit for long time. You have to change your position every half an hour at least. Half an hour. That's one thing. So every half an hour, try to stand up. That's one thing. Another thing, if you have to sit, you have to sit upright. Sitting in the upright, trying to contract the lower back muscles and sit in that fashion. When you sit in that fashion, you will have the normal lordosis and putting the muscles and the interspinous ligaments in their normal length. You don't overstretch them. Once they are overstretched, they lose their function from stability to unstable joint. And then you will use muscles that are not responsible for stability, muscles that are responsible for mobility. So we have muscles of stability and muscles of mobility. Muscles of stability, they can sustain the position for long hours. But once they are loose, you will use the muscles of mobility. The muscles of mobility cannot support you for a long time. They cannot replace their job from mobility to stability. فنقعد بشكل مناسب and let's move. Every half an hour we have to change our position.
The last question, Doctor, what about adolescent back pain? When the back pain will be alarming in adolescent who is attending for recurrent back pain?
الحمد لله اني انا درست يعني امور has to do with older adults and across lifespan and in geriatrics. ما عندنا مشكلة في أي age. The problem is with what you do and how you do it. فالمشكلة في recurrent low back pain معناها the behavior did not change. Chronic problem means chronic behavior. If we change the behavior and did whatever corrective exercises, it's good enough. احنا يونا الشباب المعضلين هذول تعرفونهم اللي كأنهم كباتة اللي بغى يدش من الباب لازم يلف عشان يدش زين كله عضلات بس لما يقعد ويقول لي دكتور عندي ألم في الظهر. The problem with the posture, the way he's sitting, and again the muscles use it or lose it. عندنا بعض الناس في المسجد about in his 80s لما يقعد على الأرض ويتربع وحق الصلاة خطبة الجمعة قاعد وظهره سيده بنص المسجد ويون الشباب يدورون الأطوف يبي يتسندون زين فهذا ما يتسند وصار عنده بالديوانية يعطونه مسند يقول خله لك ما يتسند ويقعد in the upright position ما شاء الله عليه. فهذه صارت behavior. هذه البيهيفير هي اللي احنا نبيها وبعدين عاد الاكسرسايز هي تعتبر يعني شغله مهمه كذلك لكن لازم يصير علامه النصر behavior واكسرسايز والاكسرسايز لازم يصير عباره عن لايف ستايل مو وقت يعني احتاجه وبعدين خلاص يروح فنحتاجه all the time. شكرا يا جماعه وما قصرتوا.
يعطيك العافيه دكتور وائل. دكتورة دينا بس تفضل لتكريم دكتور وائل على محاضرته القيمة. يعطيكم العافية جميعاً. It's now to break for 30 minutes for the lunch and then we will start the workshop. يعطيكم العافية.